So the Health to Go program is designed to bring expertise by helping community health workers gain capacity to be able to serve their communities, to be able to identify opportunities to prevent serious disease, as well as to detect where the health system is needed and be able to help people connect well.
This is part of our institutional mandate as a tertiary institution. We teach, we conduct research, and also offer service to the community. As part of the community service, we're doing this program called Health to Go, where we partner with our sister university, KNUST, and the University of Utah in the US, and then Ghana Health Service. We are working in about 6 communities in the Lower Manya municipality. And these communities are rural, very hard to reach areas. As we know, health is a fundamental human right. So irrespective of where the individuals live, they need to have access to health care. And so this program is just designed to offer health services to people in these resource-challenged areas of the municipality. And so per the design, we have volunteers, or what we call agents, selected from the communities. We have them trained, and then they live in the community, but then we equip them with all the medical supplies, and then they help attend to the sick children. Normally we look at children at the age of 5.
The process going on is a community-based volunteer who is assessing a caregiver with a child or a baby with a problem. So with this, the CBA assesses the child from head to toe. And any problem found on the baby, he or she recorded it in her register. And if the baby needs referral, he gives referral to the clinic or the hospital.
To help improve life in general, and help makes living much easier for our folks in this challenged environment. Now, as part of the design of the project, we do quarterly training for the volunteers. So today's session is part of the training we are having. The goal of the project is to have a pilot phase done, and lessons learned from it will help us scale up. So we now have gotten to a point where we're going to scale up to some 20 selected communities in the Ashanti region, more specifically in the Berikesi sub-district. As mentioned, we thought of learning from this project and send a message out and help send healthcare to almost all parts of our country. So those are the main focus of the project. Work with people who live in the community, equip them with resources so that they will be able to be very efficient in the work they do. these communities, as I mentioned, are communities that don't have any health facilities. We talk about even the cheap facility that we know form the basis of our health system in Ghana. The place have been demarcated as health zones where they don't have any facility. And so we selected these individuals based on the fact that they've already been working with Ghana Health Service and they know the system. So they were picked with input from the community itself. We went to the community and got their input in selecting them. And so we select them because they are the ones that have been working with Ghana Health Service for a very long time. And they are the one who knows the community very well. We focus on childhood illnesses, more specifically on malaria, pneumonia, and diarrhea. And so, since this seems to be the very basic health issues in these communities, we try to equip them with simple medications to treat malaria. We give them the rapid diagnostic test kits so that they will be able to test for malaria cases before they offer treatment. And then we give them zinc and ORS so they will be able to offer to a child who has such cases. This is a very laudable project in the sense that we really want health service to go to our folks in their communities. And so we equip them with all the medical supplies. In the previous projects we work and they pick people, send them to the community and they don't give them working tools. We give them the working tools, we bring them for refresher training so that each time we try to monitor them. So on a monthly basis we go to the communities and see the success of work or the progress of work. And then lessons that we are learning from that place is going to help inform what we do in the other areas. The hope is that eventually we'll be able to scale to almost all needed areas in our country. The advice to these agents that we are working with is that they are not medical doctors. When they live in the community, they are only to identify signs that we refer to be danger signs in the case. So that if they see this and it becomes something they cannot handle, they have referral form to refer to the nearby health facility for further assessment.
The session we are taking them through is general danger signs for all the conditions. These general danger signs can appear in any of the conditions we are teaching them to take up in their villages. And so these are the general danger signs for the program and then the conditions we have. And those are the lethargic. If the baby is lethargic or there is no strength in the baby. And if the baby is also vomiting everything or cannot eat or breastfeed. And then the third one is convulsions. And then the fourth one is when the baby cannot is sleepy, unconsciousness, or lethargic. This is what we are taking them through.
Ghana Health Service started this project. We're training our volunteers to provide care for cases with fever, malaria, diarrhea, and then acute respiratory infections. Unfortunately, along the line, we're not getting the drugs to manage them, so it died off. So when the school came in again and started, we had drugs for almost all the conditions. And so our volunteers in the 5 communities, that is Aboben, Apla, Pienwa, Gwawase, and then Atotosi, they were trained 2 per community, and they have been providing services since November 2016 up to date. They are seeing to children from 2 months to 5 years who complain of fever or malaria, upper respiratory tract infection. That's when they're having difficulty in breathing, and then when they're having diarrhea. So they assess these cases, and then they have their drugs to give to them. And since we started this project, we have seen some improvement in the conditions of the children. When we started in November, they were able to attend 11 cases for fever, but for acute respiratory infection and then diarrhea, they didn't get any case. But for the year 2017, for fever cases, it has improved. We were able to see 143 cases, and when it came to diarrhea, we had 7 cases, and then for acute respiratory infection, we have 46 cases. And I see it as a very good thing. Otherwise, what would have happened to these children in the community? Because from their end to the nearest hospital, if they want to walk, it's about 2 hours. That is support. So these volunteers in the community are really helping the members of the community, and it is a very good thing that we are very happy about, because at least we can see that there's much change in the community. And even when we come to other services like immunization, they make sure that all the children are immunized in their community. So when the nurses go there for weighing sessions, they go to the houses to call the mothers to bring their children for weighing. Pregnant women in their communities, they know them. So they go to their homes to visit them, go to their antenatal cards to see whether they have received any immunization, whether the treatment that we are giving to prevent malaria, they have taken it. When they get the cases, from their end in the community to the nearest health facility, it's about 2 hours walk. So they are attending to the cases, and it has really saved most of the members of the community. However, they have been trained to manage conditions, fever, acute respiratory infection, and diarrhea. And for all these conditions, they have danger signs that as soon as they see these danger signs, they need to refer immediately. That one is beyond them. They cannot take care of them. And we have 4 general danger signs that one too. If a mother reports the child is having, you immediately have to refer. That is, if the child is vomiting everything, the child is refusing to drink or feed very well, the child is convulsing now or convulsed at home before they brought the child to you, or the child is having yellow eyes, immediately you need to refer this child to the hospital. And then for the general conditions too, like the fever, it also has its own danger signs. Having fever for more than 7 days, you are not supposed to attend to that case in the community, so you need to refer. If the child, after assessment, has a very stiff neck, they can't move the neck, you need to refer. If the child has dark colored urine, you need to refer. If they have jaundice, you need to refer. And then if the child has pallor, that is very pale, the arms, the eyes is very white, you need to refer the child immediately. So for these general danger signs and the fever, they need to refer. But if none of this presents, they can manage in their community. They have their drugs there to give, and they have been trained to test for malaria. So even for that one, if you test and it is negative, you refer. because you didn't identify any malaria in that person's blood. So you have to refer the person to the nearest facility. But if you test and it is positive, they have the anti-malaria drugs, the artesunate amodiaquine, to give the children. The same applies to acute respiratory infection. If the child has coughed or has difficulty in breathing for more than 7 days, you refer. If the child has stridor, you will say that when the child is breathing and there's some noise behind it, it's a danger sign, you need to refer. And at times, if the child is breathing and the chest goes in, that one too, we call it chest indrawing. That one too, they need to refer. So as soon as they see these conditions, they have to refer. Aside that, if it's just a simple cough, they have the amoxicillin there to give to the children in the community. And when they are managing their diarrhea cases too, they have ORS and the zinc tablets to give depending on the age. If the child is less than 1 year, they give 10 milligrams. If it's more than that, they give 20 milligrams. But during the diarrhea, they also have their own general danger sign. So if the child is dehydrated, they have sunken eyes, you need to refer the child immediately. If you press the feet of the child, the arms, and you realize that it is pressing very deep, we call it edema. You can also do skin pinch. You pinch the abdomen to see whether to go down very fast or not. So if they also do the skin pinch and it takes a longer time for the skin to go back to normal, it means the child is dehydrated. So they need to refer this child. Aside for these conditions, if it's just normal diarrhea, within the first 7 days, they just give the ORS and then they refer. However, if there's blood in the stool, they need to refer because it's also a general danger sign for diarrhea. We've also trained them to even identify some of the danger signs during pregnancy, like bleeding, having paleness of the eyes and then the arms. They can also refer them. When the woman complains of severe headache as a pregnant woman, they need to refer the person. So all these things they have been taught what to do. And for the babies too, that were born into the community, if they come in and they have very high fever, they are very cold, they are not feeding very well, you need to refer them because these children are below 2 months. And that one is not cases that they are supposed to see in their community. But just to help them identify some of these cases in the community, we have taught them. So when they go into the homes to visit and they see such conditions, they will refer them immediately. So I do not say that these children are not part of the children I'm supposed to take care of, so I'm not going to see to them. It has been very helpful because our community health nurses go there once a month, and even that is just to conduct weighing sessions for the children. So for these community members to be in their community, trained to see to such cases in their community alone is a plus because they are helping a lot of children from dying, which is very good. And we really appreciate the school for such an initiative.
Every month we're supposed to go for outreach services where we immunize the children against some diseases. Even community mobilization was a challenge for us. It was very difficult for us to mobilize the community to bring them together. So we're going there once a month, and the once a month we were not even going to all the communities. So we meet at one point and then they come to Wawase, which is one of the communities under the Wawase Chief Zone. But with the help of Health to Go, now we can go to all the 6 communities that we have under the Chief Zone, and then we have immunization. So when you compare the immunization trend from the time Health to Go came in and now, we know that it is also increasing. And then also at first when we go for weighing, we used to see a lot of sick children who are coming for the weighing. They wish we can manage or treat them, but because that is not what we were going there to do, we couldn't treat them. But for this Health to Go project, when you go and you meet the children, you see that they are healthier, and then their nutritional standard is also going up because of the health education the volunteers have been giving onto them. So with this Health to Go project, it is really helping the municipality in all ways. In terms of surveillance, when we go for community outreach with the Health to Go, they come out with challenges or diseases that they've seen, but it's not part of the project. They said previously they used to have guinea worm at that side, but now they are not having the guinea worm now. But what is worrying them is something was trying to come up like the guinea worm. We were notified earlier, and then what we were supposed to do, we did it for them. So Health to Go is helping the municipality.
This first project is designed to test the approach. We are working with some communities in the Lower Manukrobo district near the community of Wawasi, and it's designed to help us understand how to practically apply this program. The goal will be then to now test it in a larger environment, and ultimately to be able to have it as a resource that can be distributed countrywide. When we developed Health to Go, we realized that there were some challenges with community health programs. Those challenges included that training was often one time and not ongoing, that there needed to be clear integration with the health system, that the equipment that people use needed to be rigorous for the demands of the jobs they were doing, and they needed to be able to adequately connect with other services when community health work was insufficient for particular severe cases of disease, for instance.
It is our plan also to extend this program to Ashanti region of Ghana, the Barekesi sub-district to be specific. And in the same vein, we would have community-based volunteers being trained, and we have supervisors to follow them up, and they would be going to the homes of caregivers to educate them on some of the issues that affect their children. Specifically, pneumonia, diarrhea, malnutrition, malaria are some of the key health challenges of children. And these community-based volunteers are being trained on how to quickly assess the diagnosis with the mothers and be able to do the appropriate referral to the health centers. At the Barekesi sub-district, the current numbers, there are about 22 sub-districts, but currently we are selecting about 11 of these sub-districts, which is about 50% of them. And the selection of the volunteers is already gone through. We've had the facilitators and the support supervisors also selected, and they are going to help with the training in monitoring of the program at the sub-district level. And so we believe that we're going to do a bigger coverage at the Barekesi sub-district area where we're hoping to start the program.
For this referral course, help us to identify or to know that when you test the child and then the child has a hot body, and then you do the RLDT and then it's not positive, you have to refer so that the doctor himself or the nurses should look for the rare cause of the body hot so that they should treat. But at the first, if we see that the child has a hot body, we just give para and then we keep the child in the house. So you will see that the problem continues. But now, through the refresher course, we see that we have to give refer so that they should continue and then find the actual problem of the hot body.
So we've tested this for the past year, and we've seen some dramatic impacts from the program. We've seen over 3,000 visits to households in providing training to help with health literacy among households, to help families develop good preventive practices. We've also seen treatment of many of the common diseases that are quite severe and impactful on communities, like malaria, respiratory diseases like pneumonia, diarrheal diseases. And we've seen the ability to get severe cases integrated and treated at health facilities, and with over 40 children during that time treated for severe disease that really does need the health system. We're so pleased to be able to do this here in Ghana. It's an opportunity for us to learn and partner and work together with our colleagues from around the world. This is a program that not only we believe will help the country of Ghana, but will impact the world, as many communities around the world need this type of support. So we're very happy to be here.